Good afternoon, everyone. This is Carrie Lopez. And I know we have a title that we want to be a little bit of a mystery, so we're going to go through and share programs here in the Northwest. And I titled this Bringing Tribal Cancer Plans to Life because those of you who have your strategic plans sitting on your shelf and your cancer plans and your nutrition plans, what we really hope that we're going to have you walk away with today is some ideas of how to do some cancer prevention activities in your tribes and kind of on a shoestring budget. So Eric's going to talk in a little bit more about how you apply for our little implementation funding. So I'm going to start out by giving a little information on our organization. We're from the Northwest Portland Aryan Health Board, and this is a map of the 43 tribes that we work with here in the Northwest. And as you can see, kind of a big area. I always like to open with our organizational chart because we are a 638 contract. We're a tribal organization, and we're an Indian health board where every single one of our tribes is a member of our health board. So our little chart here shows our executive committee on top, and then our director, Joe, the epicenter. But I always kind of like to point this out because everything we do here in the Northwest is truly governed by our tribes. We take everything to our quarterly board meetings. All the projects we work on are passed in resolution at the meeting. And also our tribal leaders bring forward projects they want us to work on. So we really, truly work for our tribes. So if I have any Northwest tribes out there listening, hello, bosses. So then you'll see that our program falls under the National Epicenter. And we are also part of the National Native Network. We're one of the partners. And I realized that we failed to put Intertribal Council of Michigan where the project's housed. Then there are our partner organizations, CRIB, South Alaska Regional Consortium, the Great Plains, and us, Northwest Portland Aryan Health Board. So here's our objectives, and Josh talked about them earlier, but I also like to share I am a member of the Tolowa tribe in Northern California. So the picture on the right is my grandmother. She passed a few years back, but this was a Curtis photograph that was taken as close as we know when she was about 16 or 17. And it was right before we no longer could practice our religion. So there was a generation that skipped. So that's Ada Richards. And I like to start with that because that's my own history. So we're going to share some tribal cancer prevention activities today. Eric's going to go over what we call the Tribal Cancer Plan implementation. So those of you who have grants also know, we used to call these mini grants, but CDC, because they're small, they don't want that term anymore because of all the documentation. So they're local cancer plan implementation now. And then we hope to give you a little bit of an understanding of the different communities because when you saw that map, our Northwest tribes are very diverse, not just in culture and language, but also we have our smallest tribe is 96 members, and then we have Colville and Warm Springs and Spokane that are much, much bigger.
11,000.
Yeah, about 11,000, our biggest tribe. So we have a lot of different communities we work with here. And I really feel that they have been very creative, and I hope you're going to find that by the time we're done here today. One of the things that made our grants work or our programs work is the tribes are able to do what they want. So we have a lot of different projects that go on out there in our community. So our tribes work with youth, they work with the elders, work with family. We have in the last few years seen a big increase in nutrition and physical activity that we really love. Tobacco's been going on a while, and also sun safety, which was a new one, and Eric pushed very hard, I think, trying to get that out into our communities. So we have one of our youth programs that 1 year with their funding got visors and sunblock and water for staying hydrated, so it was a focus around being safe in the sun. And then a little more traditional for screening, we have a programs that have done breast and cervical cancer over the years, and you'll see some of those also. But we have several programs that have done women's health days, where there's the mobile MAM comes in, the primary care providers do scheduling. They try and make them fun and rewarding. So a lot of the programs will have gifts for the women. They'll have a massage therapist there. They'll have nice creams and lotions, and often give a gift certificate for the women who come in and take care of themselves, because we all know that it's hard to make time sometimes for ourselves. And then we also have done a lot with our colorectal screening, because we have Kiki, our inflatable colon, and Kiki has gone out to many, many tribes in the last few years. We had a little naming contest, so I really like that we ended up with Kiki, because one of the staff here said it kind of sounded like a stripper name, but I was like, well, that girl gets around, so it's apropos that Kiki ended up the name of our colon. And then, of course, we have a number of tribes that have survivor groups, and over the years we've had bigger groups, smaller groups. We're going to talk a little bit about one of our very successful survivor programs here in the Northwest. But again, our tribes have been very, very creative. So we have walks, we have powwows, there's support groups, honorings that happen. One of our tribes early on worked with American Cancer Society and did res runs. So they were very involved with ACS and partnered. And
so to give you a little background, thought we'd look at the tobacco use here in Oregon as well as nationally. And this slide kind of speaks for itself. You can see that nationally as well as in Oregon, the non-Hispanic white smoking rates as reported by Burfus are pretty similar. And you can see the confidence interval there on the national numbers. For Oregon as well as nationally, American Alaska Native rates are significantly higher. Oregon a little bit higher than the national average, and obviously various areas within the U.S. have varying rates of smoking. But within Oregon, we're at about 35.3. So the impact of that really, you can look at a number of different things, as we learned with this last year's Surgeon General's report. But if we look at lung cancer, we can see that the incidence in Oregon is statistically significantly higher for American Alaska Natives at 84.6 per 100,000. And the end result of that is we also have a higher mortality rate. So there's the Oregon rate there at 68.6. And then nationally, there was a report done this last year for American Alaska Natives, and you can see that's 55.2. So the unfortunate reality is, even amongst those and the nationally, we have higher mortality, but then we also have that higher mortality in Oregon. So talking about the actual cancer plans and how that works. So our grant fiscal year for the Northwest Tribal Comprehensive Cancer Program starts July 1. So for us, we're really busy kind of getting the year started. So when it comes around fall, winter time, we send out our applications to the tribes. And that really kind of works well for some tribes that may be planning things beginning part of the year, maybe for Colorectal Cancer Awareness Month or Cervical Cancer Awareness. And then that we have it rolling. So if a tribe wants to kind of apply earlier, we encourage that. If there's a great idea that comes around, or maybe a person in a position that wants to apply for something a little bit later, they can. And we put April as the deadline because really, you know, around April, you're looking about 2 months until our June 30th end date. And at that point, you know, you've got a very short lead time to plan things. So the tribes that have applied earlier, you know, they've got the funding, they've got their activities planned. But those have kind of maybe procrastinated a little bit. We have that deadline to kind of help to spur the applications to be submitted. So as I mentioned, our project wraps up June 30th, so we ask for the projects to do that. So that's the end of our fiscal year, and then we ask as part of the project that they evaluate and report on it. So this year, we emailed out. Most people have email nowadays, which is pretty handy. And so middle of October, we emailed out, and then we also discussed it and disseminated print versions at our coalition meeting in November. So this is all, you know, about 6, 7, 8 months before our end of fiscal year. So there's hopefully sufficient lead time to go through the processes that are necessary to get approval for application and submission. So we also reach out to tribes, kind of starting in the new year. We call, basically, in addition to talking about our upcoming activities, encourage people to apply and have that discussion about what people are interested in doing and what's meaningful for their community. So in terms of the application, we have our request for proposal, and on the front we've got the CDFA number, and if any of you have worked with federal auditing processes, you'll know that any of the funds you get, you want to know the CDFA number. So we've added that in more recent years so that that can complete the process for the tribal finance departments. And then we have a really nice little action planning worksheet, and I'll get to that in a couple later slides. And that's really simple, but it really helps lay out everything. And then we give some references. So one is example activities. So there's like a little paragraph description of the different activities that different tribes have done, kind of spur the thought processes about things that might work for a given tribe's community, or they get inspired and think of something new. We also have an example proposal, because really it can kind of be scary if you're not a grant writer to write these sorts of things. And I'll mention briefly that this whole application process is designed to be as easy and accessible as possible, because the reality is these mini grants, or these implementation funds, excuse me, are $3,000. So the amount of paperwork you want to have for a $3,000 amount of funding relative to a $200,000 amount of funding should be proportional. So what we've asked for is the cover letter on letterhead, and then for it to have gone through whatever appropriate processes, as well as the action planning worksheet, which I'll show you, and it's pretty straightforward. And we've also got an action planning worksheet kind of filled out along with the proposal. And then very importantly is our 20-year plan objectives. So there's the comprehensive cancer control plan for the region, and in there we have a number of objectives addressing all those things that Carrie had mentioned. And we really want to connect what tribes are doing to that plan so that we can both demonstrate how our program's having impact in the area, as well as supporting the tribes in a meaningful and structured and well thought out manner. So here's the letter that went out middle of October, and I put it in here kind of as an example of, the cover letter from the tribes could be really straightforward. I mean, this is on our letterhead. It's got a signature here. It's, it's describing what's in the application. And so we really are looking for this on letterhead to make sure that it's a legitimate application from the tribe, and that it's gone through the appropriate processes to be submitted. This is our worksheet, and so this is sourced from a 88 publication, the Executive Guide to Operational Planning, and it allows a person who maybe hasn't really written down what they've done before to write those steps down and to identify the person who's going to be principally responsible. And it may be one person does almost everything, or if you're working in a team, you'll want to have the people that are working on each specific element to be identified, so that later if there's an issue, that you can go to that person and say, hey, you've committed to doing this, this is the thing that you're supposed to be doing. And then others, because of course a lot of times, if you're talking about maybe setting up tables for an event, you might have the organizer, but then you'll have a whole crew of people working on it. And schedule, because it's always important to have idea in mind about when you should start and stop things. So the planning doesn't happen after the event, or silly things like that. But just writing it down can help to structure your thoughts and put together a plan for a successful event. And then, of course, resources. So, they've got some funding from us, but then there's also potentially some other expenses, and, they may be coming up with those funds from other tribal health programs or other entities, and to identify how much time is going to be involved so that you have a appropriate amount of resources for it. So if it's, like I mentioned, maybe setting up tables 30 minutes before, you've got, a handful of people to go do that. And then what sort of feedback? So typically that's in the form of like a survey to the participants. You've got your programmatic measures as well as satisfaction. And then in some cases you can look at maybe referrals out to colorectal screening or breast cancer screening, or as Carrie was mentioning with the some of those screening days, you've actually got numbers of people screened. So as far as who's doing this, so within the tribes, we have our delegates, our health administrators, or health directors, the social workers, nurses, community health representatives, cancer survivors. Basically everyone you can think of from a tribe is involved with these activities. And as far as programs, they come from a wide variety of programs. So there's not, as you may be aware, tribal cancer projects. So there's not funding from IHS or the federal government to help support individual tribes having cancer navigators or others working on to address cancer. And so we've got people that are coming from community health, the maternal child health. We've got a couple of maternal child health nurses that are very much involved with our program and have written grants. Of course, tobacco programs in Oregon and Idaho, we have tobacco coordinators. Unfortunately, in Washington, they've defunded all the tribal tobacco coordinators, so we don't have them to work with. But in Oregon, Idaho, there's colorectal cancer staff within some of the member tribes. We've got a couple navigators that are funded through tobacco programs. There's some of the traditional foods programs. As Carrie had mentioned, nutrition has really come to the forefront in the past few years. Behavioral health, some of them are working on tobacco cessation, and then we also had a number of the community transformation grantees we'd collaborated with. In terms of partners from outside of like tribal health, of course there's support from tribal council, casino. I mean, a lot of the programs will use the casino printers and, make up some really nice glossy posters. There might be some support from tribal enterprises, like some of the tribes that have water bottling and can get some water for the events and things like that, as well as, the usual like Komen and ACS. USDA has been a partner in terms of some of this nutrition work. The CDC-funded state breast and cervical cancer projects, as well as some of the tribal breast and cervical projects. Some local universities have brought in expert speakers or some expertise to really support these activities. So whether it's a nutrition expert or maybe a pharmacist who can speak to erectile dysfunction issues for men who've had prostate cancer treatment, that sort of expertise that can be drawn from local universities and colleges, as well as local cancer centers. So some of them have supported tribes by having a booth or maybe with some sunscreen for some of these activities that are outdoors, and many of those sorts of things.
So we're going to talk about a couple of the programs that they've all been successful, but we're going to highlight a couple of programs. And I would like to add, just kind of, Eric does a lot of work getting the tribes to get these grants done, and he has also been a speaker at several of their prevention activities. So I wanted to give Eric a shout out because he's gone in and done some work when the tribes have these events. So I really appreciate that, and the tribes appreciate it. And the other thing is we're really trying to get some resources back to our tribes. $3,000 is not very much, but part of the reason we do it like that is you don't have to document it then and do it as a contract. So it's kind of the magic number for contracting. and we can do it as local implementation and not have to go through setting up contracts. So we're hoping we make it easier. If someone from CDC's out there listening, you know, when you up our grants to 100,000, we can get a lot more back to the tribes, and we'll contract with them. So shout out for more money. Always have to do that. But this is a men's golf retreat that came out of one of our tribes. We had a very good working relationship with the health educator that was up there at the time, and she really was trying to get her men in for just hearing about cancer and cancer education and, you know, prostate and colon cancer, and called and said, so I'm thinking I want to do a golf tournament. It was like, okay, we can do a golf tournament, but it has to involve trying to reach out. So Krista was very creative in putting together a program where there was education that happened on the holes out on the golf course. Little cards were put on the greens, and then as part of it, there's a luncheon where they have a keynote speaker that comes in every year and talks about colon cancer, prostate cancer, whoever they can get in as an expert. So she did a really good job of really making it work, and she has done it for a few years now, as you can see. And each year it got bigger and bigger to the point where now the men at the tribe are like, so when is our golfing tournament happening? So I really thank her for hanging in there, and I think other tribes have done it. In the meantime, I hope you'll take this away. Maybe this is one of the ways to reach your men. But again, you can kind of look at over the years, they started with 8 men coming, and now it's up to 20 men that come and play in the golf tournament. One of the other things there on the bottom, we have the outcome. One of the other things that Klamath did, and this is actually not part of the men's health, but they had very high smoking rates and weren't doing very much with it, so they created a program to, it was a competition with the providers at the clinic, and it was basically they were referring to the quit line, but between a provider and her medical assistant, they had a 600% increase in referring people to tobacco cessation. So that was just one of the other successes that happened with Klamath. So we are very proud of them and what they did up there. And just as kind of a sidebar to that, when we did some of our BRFIS work with them, that also showed in the BRFIS, the quit rates for that period when they were doing the provider competition. And again, talk a little bit about men, because I don't know what's with you dudes, but you guys are hard to reach out there. So one of our other tribes wanted to do a men's wellness day, and they really did a great job. Eric talked about those partnerships. They made it, they partnered with the tribe, they partnered with industry. The tribe gave folks time off during the day to come over to the event. Very well coordinated. They had great gifts for the men. They did drawings all day long, and they had all of their different departments that came in. So their police department, the fitness, chemical dependency, the WIC program, women's health, tobacco, maternal child health. They really all pitched in and made the day successful. And you can see the little thing at the bottom where there were 114 participants last year. And then this is one of our tribes who actually has a tribal cancer coalition. So from that day, they got 10 men that joined the Tribal Cancer Coalition. And also, this is one of we have 114 participants there, but when they started doing this day initially, I think they started with 30 participants, and over the years it's grown. And they do, every other year, they do a men's wellness day, and then the next year they do a women's wellness day. So they've had, again, huge success, and Eric Stana participated in this one. And for my Northwest tribes again, He's very helpful. If you don't have him as a speaker, he will help set up and tear down and be very active and a part of it. And then this is the third one I'm going to talk a little bit about. And again, this is one of our tribes who had a breast cancer support group, and they worked very hard getting women to their group and having speakers and presenters. They did a dinner, and I think the big kind of shout out here is for the tribe. They have a social worker and a nurse case manager who have part of their job is doing this cancer survivor group for their women with breast cancer. So there's 15 women in the group now, but what also happened in the outcome here is they have another staff member, another nurse, who's now doing a cancer survivor group for all cancers, because they had a lot of folks come in that were not breast cancer survivors, but other cancers saying, we feel like we want the support, you're doing a great job. We've heard very positive things from the women who come to your group. So this particular tribe now has a group for all other cancers. And they're very active in the coalition. We really appreciate their input. And I know that one of the things that they've really loved, one of our resources we developed here in the Northwest is a patient navigator appointment companion, where you can track your doctor's appointments and your meds. And they love our appointment companion, and we appreciate that because they've given us a lot of positive feedback. And I think on that, our hit-up batter is Antoinette. So that's not the right term. What do you call it? Cleanup batter.
Cleanup hitter.
Antoinette's cleaning up today, and she's going to go into depth talking a little bit about one of our Oregon tribes. But I did want to say that for us here in the Northwest, the tribes in Oregon have been working with the state of Oregon through the Oregon Health Authority since 1994, and that's when we worked to pass the tobacco tax, and Oregon at that time committed funding to the tribal programs just like they did the county. So the tribes here have been working with the state since 1994, so I wanted to just turn it over to Antoinette.
All right, so this success story is on Scott Klama and the Confederate Tribes of Warm Springs, and on the picture here is Scott Klama, and he is a tobacco prevention specialist for the Confederate Tribes of Warm Springs, and he helped the National Powwow's first commercial tobacco-free event in February this year, so it was a very big thing for them. And for Scott to accomplish this with the community, he addressed the powwow committee. He brought him information on talking points. He gave him data on surveys that he held in the beginning, and just brought a bunch of information to hope to see if he can get the community ready and on board. And bringing all this information to the committee, and the head of committee, Matthew Begay, he agreed to go forward. So before the powwow began, he raised awareness saying that this was going to be a commercial tobacco-free event. He worked with the local newspaper and the local radio promoting this, word of mouth, and he also did a bunch of signs beforehand. He also did signs at the powwow and regulating this. So he also went to, since it was their first commercial tobacco-free event, he wasn't sure how to go about and where to start, so he got help from elders in the community. He gained additional help from other tobacco prevention specialists in the area. Also, his liaison, Tara Weston, she directed him to the SmokeFree event toolkit, which was done by NARA, the Native American Rehabilitation Association, which is you can find on the SmokeFree Oregon website. So he read through the toolkit and he followed the steps the way it's outlined. It has all the information and how to go and having a smoke-free event. They also have other ones for smoke-free housing, parks. And so these are just an example of a couple of signs that Scott used. On the left is the signs that he used before the event. he posts these up about a month and a half before to give the community time and be prepared to know that this is going to be a commercial tobacco-free event. At the bottom, it talks about a little bit of the reasons why and who to contact for more information and who to visit for like the website if they don't want to talk to him personally. And on the right-hand side is the example of ones that he used during the event. Again, it has information who they can come in contact with. And he also had other signs, but these are just some of the ones that were in the toolkit that you can use. So they're just examples. So he did them a little bit differently to address their tribe. So another key thing that Scott had to face was knowing the difference between commercial tobacco and traditional tobacco. Most people see a commercial tobacco-free event, they assume that it's traditional. So Scott had to stress that there is a difference between the two. And so this he pulled from the toolkit as well. So he used this as signs as well. He handed these out at the powwow so people knew the difference. He also used, handed out talking points and information on the positives of the having a smoke-free event, you know, protection from secondhand exposure and things like that. So, and again, all these he was able to get from his tobacco prevention specialist that he talked to, and also in the toolkit. So part of Scott's background, he's a tobacco prevention specialist for Oregon Tobacco Prevention and Education Program, also known as TPEP. Their goal is to reduce tobacco-related illness and death. TPEP is part of the Health Promotion and Chronic Disease Prevention section in the Cancer for Prevention and Health Promotion. Back in 2008, World Health Organization, the WHO, introduced the Empower framework to prevent and reduce tobacco use. Empower is composed of 6 measures that have been applied to public health authorities across the globe. So those are monitor tobacco use and prevention policies, protect people from exposure to secondhand smoke, offer to help people quit tobacco use, warn about the dangers of tobacco, enforce policies that reduce tobacco exposure, and then raise awareness of tobacco. So the TPEP developed and took on this Empower framework and put this to use. So these are some of the things that they were working towards. And one of the big things for Scott and barriers was public readiness. So before he even decided to have a commercial tobacco-free event, he conducted a local survey to see if the public would support this, if they would be behind him. And so in doing this, it generated lots of positive feedback for Scott in deciding things. The public is ready to have a commercial tobacco-free powwow, and this is some of the information that he used and presented to the powwow committee and what got them going and agreeing with him and letting him, yes, okay, we are ready for this, we will do this. So that was one of the big key points in this. And then also from the survey that he had, there are a lot of notes that were given on there saying that they really stressed the importance of protecting, getting protection from secondhand smoke, which that would come about when having a smoke-free, commercial-free event. And a couple big successes from this is that they invited the Cokies film crew to come down and film their success of the powwow, and so they were able to show that they were able to have the powwow smoke-free, and that it also expressed the traditional side of the Confederate Tribes of Warm Spring. And then another big takeaway that happened was the Confederate Tribes of Warm Springs can make a difference by taking a stand against commercial tobacco. Some of the information that Scott handed out was the definitions of the two for those who didn't know, and then and to get a better understanding of it, and then also understand the tactics that are being used by big tobacco and how they target Native Americans. So he was really able to give out a ton of information to the community that wouldn't have gotten beforehand. And So he thinks that his next step would be working on smoke-free apartments is his next big step that he's doing. And so we do have the film that Coach Koki filmed on them. And here, if you can highlight the link and you can play it, it's only about 2 minutes, I believe, but we have the video, which we can show you a little bit of it, but there's no sound. So I'll just play a little bit. You can see of the dancing and some other things like that. All right, so that was just a little tidbit of it. I really encourage you to go check it out and look it up. You can either copy the link, you can see it on the SmokeFree Oregon website. It's on there. It's one of their main head points right now. And then that's also where you can also look up the smoke-free event toolkit that Scott used.
Okay, so we're definitely not taking an hour, and we knew that right off. But in closing, we just kind of hope that everything we've shared here gives you ideas. Will spur you to work with your tribes, maybe to partner and get some sponsorship. So here in the Northwest, I felt like we're very fortunate. I hope that folks on the line got some great ideas. Over time, you can see some successes. And I think the big thing, the implementation here is that we love that it goes back to the tribal community. There are community champions out there. This happens because of our folks who've been committed to working with us in the Tribal Cancer Coalition, who come to our meetings, who work with us. So we really appreciate them a lot, and we love giving the support, but it's really about the tribe, and we love that it empowers the tribe. And then here's one of our little pictures of Kiki. Again, I said the successes for us is that the events truly are community owned. The tribe plans it, implements it, evaluates it, and hosts it. And it's empowerment for the community, also getting education and making cancer prevention part of their culture. So we love that our tribes apply. And if any of you are out there and haven't applied yet, call Eric today. And then in closing, I just always like to kind of put a listing of the different things that we've had our tribes do over the years, because, I mean, I remember, gosh, it's probably in 2004 when one of our tribes did the first Papathon and Mammothon, and I thought that was like so great. And I set the stage for doing competitions with some of the tribes about like who could get the most pap smears and the most mammograms. And then we had a tribe that done the Pink Paddle Project. Coleman Grant was our the canoe journey. They had a team in the canoe journey races. We've had tribes do the Pink Shawl, mother-daughter teas and lunches. I talked about the golf tournament. So just trying to give a listing of the different things we've had our tribes do here. And if anyone has questions about any of them, don't hesitate to give us a call. The picture down there in the corner is my staff and some of the Grand Ronde tribe, and that was the breast cancer awareness activity that happened. So the casino did an all-pink night and did breast cancer awareness, and there was honoring of survivors and fundraising, and it was very, very successful. So Eric worked hard on that bingo game for breast cancer awareness, and we're glad to share any of our resources we have here from the Northwest Portland Area Health Board. And there is our contact information. The only other thing, and I don't have a slide on this, but I did kind of want to make sure we have some upcoming events. So we have a coalition meeting on June 25th that is in Warm Springs. A huge agenda. It's a partnership program. Antoinette's presenting on e-cigarettes. Eric's doing cancer survivorship. I'm going to be doing chronic disease prevention. We have our WEAVE project specialist, another project here at the board that's going to be presenting on nutrition. So that's our year-end coalition meeting. And then, because I wear two hats, I'm also the director for our diabetes program here. On September 1st and 2nd, we have the Nike Native Fitness training that we do here in the Northwest, which is a national training. And I'm actually going to ask Robin and Josh to post that on the National Native Network site, but it's also on our webpage. So it's an event where you come in and you work with trainers on boot camp, on fitness, on traditional kids games, and hopefully you take the curriculum home and implement it on the home front. And in addition to that, we have Daryl Tonema, who comes in and does motivational interviewing. So if you're interested in our Native Fitness, get registered, go to our webpage and get the information. And on that, there's all of our contact information. And if folks have questions, we would be glad to answer any questions. Really hard talking to a phone, by the way.
Yes, if anyone has questions, you can just type them in on the box under questions, and I'll read them off. Give it a few more minutes. Some people might still be typing. Oh, we have a question here. Can you talk more about your collaboration with the maternal and child health staff?
Sure. So the collaboration there is with a couple nurses at one of the tribes and child health programs. There's obvious connection with the tobacco cessation, the breast and cervical screening as far as women's health checks. And I think in part because of that, and in part because they're tribal members of their own tribe, serving their tribe at their health program, they have seen the impact of cancer on the community as well as their family, and really felt passionately about cancer issues. And so in addition to addressing tobacco and those screenings I was talking about, one of them had their position description written with additional responsibilities to support cancer patients at the tribe. And so with that, they have gone to patient appointments and really helped to coordinate and support communication with those patients that they're helping. So that's, I think, the connection there, and it's a very strong one because, as I mentioned, they're part of the community, and so it's not like some nurse from outside coming into the clinic that it's a 9-to-5 job. At 5 p.m. they're done. 5 p.m. they may be going to a fundraiser. They've done numerous bake sales and golf tournaments and different things to raise funds to support cancer patients in their community.
And the state of Oregon has funding for 3 nurses in tribal programs that they support. And we're recently just starting to work a little bit with a couple of the clinics because we have very high smoking rates for our pregnant American Indian Alaska Native women here. So we're looking at a partnership with the state to do some training around tobacco cessation with the maternal child health nurses.
Thank you. We have another question. Looking for data that sheds light on cancer incidence and other diseases related to use of traditional tobacco versus commercially produced tobacco.
So with that, I mean, that sort of nuance, unfortunately, is not in the standard CDC BRFIS questions. So you're really not going to find it out of the national data. I mean, the BRFIS data I presented earlier, some of it was from the national reporting in 2008. And so that's the last time that I'm aware that it was analyzed nationally for American Alaska Natives for various risk factors. Having said that, there's opportunity with the individual tribal BRFIS to augment the questions from CDC with a question that would be appropriate and applicable to the community's usage of traditional tobacco. So it's really going to be dependent on some resources available to do a local BRFIS and to add those questions.
Okay, I don't see any more questions coming in, so thank you to Carrie, Eric, and Antoinette for their presentation. Thank you for everyone attending the National Aid Network Technical Assistance webinar. You'll see a survey coming through your email probably tomorrow. You can take the time to complete that survey. It would be much appreciated. Miigwech, thank you, everybody.
All right, thanks, folks, for dialing in. We appreciate it.
By the end of this webinar, participants will be able to describe the disparities in colorectal cancer incidence and mortality and how this may be impacted by screening, identify the latest screening guidelines and methods, identify strategies that can be used to improve screening uptake. Questions will be answered during the last few minutes of the webinar. Please type your questions into the chat box on the lower right hand of the screen. And Dr. Perdue.
All right, everybody. You should say good afternoon. I'm David Perdue. Thank you for the kind introduction. I just make sure you can't see my title slide, correct?
I have switched the presenter to you. All you have to do is click show your screen.
That's it? You can see me? Or you can see it? Fabulous. All right, well, welcome. It's a cold day in Minnesota, and very honored to be asked to come and talk to you about a lot of the projects we have going on in Minnesota, as well as just colon cancer in general. And we're going to get rolling here. Hey, if I can figure out how to advance. There we go. I've already been introduced. Again, my name is David Perdue. I'm enrolled in the Chickasaw Nation of Oklahoma, and I work in Minnesota. I've had a great introduction, so I'll move on. We're going to talk a little bit about epidemiology of colon cancer, the risk factors for colon cancer, some screening options, a little bit about barriers to screening, and possible solutions. I want everyone to keep in mind that 95+% of colorectal cancers actually follow what is called the adenoma-carcinoma sequence. What does that mean? It means that colon develops genetic abnormalities that lead to the formation of polyps, and these polyps are not cancer yet. We think that about 1 in 10 adenomatous polyps can develop into cancer. It may take between 8 and 12 years to do that, and we know that by taking these polyps out, we can significantly reduce colorectal cancer. This is a very complicated slide. Obviously, it's past the, I guess, level of what we're going to talk about, but I just want people to see that you start developing these different genetic abnormalities. You get methylation abnormalities, you get some tumor suppressor genes that go awry, and the next thing you know, this polyp turns into a cancer. Colon cancer is staged based on the depth of invasion of the cancer. So in stage 0 cancers, we're really still in the mucosa, and these are the ones that we can actually take out with the endoscope. So a patient comes in, goes home cancer-free. Once we're at 2, we're starting to get it, or sorry, once we're at stage 1, we're actually getting into the muscle layer. Same with stage 2, we're deeper. These cancers can be treated surgically and don't require chemotherapy, but by the time we get into stage 3, we've got cancer into lymph nodes, and by the time we get into stage 4, that cancer has spread to other organs. This is really critical because 5-year survival is completely dependent on the stage in which we catch these cancers. Again, if we get these cancers in the very early stages, it's over 90% 5-year survival. A lot of these patients are cured. By the time we get to the regional lymph nodes, it drops to 67%. And unfortunately, if we don't catch it until they actually have metastatic disease, 5-year survival is less than 10%. So let's talk about colorectal cancer epidemiology in American Indians, predominantly, and some about the Alaskan Natives. We look at the leading causes of cancer death in American Indians. Lung is usually the leading cause, but interestingly, colon cancer is actually the leading cause of cancer death in non-smokers. If you look at individual genders, men have more prostate cancer, women have more breast, but when you combine the genders together, colon is, again, the second leading cause of cancer death. People are often surprised to know that your lifetime risk of colon cancer is about 1 in 17. A little bit higher for men, but not much compared to women. Just this last summer, we actually published an update looking at colorectal cancer incidence and mortality, as well as stage among American Indians and Alaska Natives in the American Journal of Public Health. In this project, we looked at colorectal cancer rates in what are called CHSDA counties. Most of you may know what that means, but for those of you who do not, CHSDA stands for Contract Health Service Delivery Area, and these are the counties in which the Indian Health Service provides services. So most people that receive Indian Health Service care or who are eligible for the Indian Health Service to pay for services not available at their local tribal health facility live in these counties. So these are counties that have a enriched population of American Indians, and this kind of maps out to where a lot of the reservations are, of course, plus the state of Oklahoma. And if we look at colorectal cancer incidence, this is the number of new cases in a population per 100,000 people, and we age adjust that, and we look at American Indians and Alaska Natives grouped together. There are Alaska Natives that do not live in Alaska. And we compare that to non-Hispanic whites. What we see is the following. For non-Hispanic whites, colorectal cancer incidence is pretty stable across all these areas. And again, if you look at the little map at the top right, you can kind of see where these are. These are Indian Health Service areas. And but what we see are interesting, dramatic differences among American Indians by region. We see the highest rates up in Alaska. Northern Plains and the Southern Plains come in second. And again, their rates are quite a bit higher than non-Hispanic whites. The East Coast data is a little bit rough just because we don't really have the reservations and things in the East Coast, so the numbers may play a role in why those are low. But if we get into the Southwest, they have colorectal rates that are significantly lower than non-Hispanic whites. And if we look at mortality by region, so the number of deaths per 100,000 people, not too surprisingly, we see pretty similar trends. Highest in Alaska, the Northern Plains, and the Southern Plains, and the lowest being in the Southwest. And with the exception of the Southwest, mortality or deaths are higher among the Native population than the white population. This is kind of a confusing slide, but this is a way of looking at colorectal cancer mortality over time using this fancy CDC way of looking at things. And what you see in the purple line is actually non-Hispanic whites going from 1990 to 2009. You see these rates have just been falling, and those rates that is a statistically significant decrease over time in non-Hispanic whites. At the same time, if you look at the red line, that's American Indians and Alaskan Natives. And even though the slope is somewhat upward, it kind of appears as if mortality rates are actually increasing. That change is not really statistically different. But so what that tells us is mortality really is not falling in American Indian and Alaskan Natives like it is in the white population. If we look at how cancer is staged or what the stage is when people are diagnosed, we see that if we focus on the left, that's for the United States, that American Indians and Alaska Natives tend to be diagnosed with more often with late-stage colorectal cancer compared to non-Hispanic whites, and on the right side the data is just more specific for the Northern Plains, which is where I do the majority of my work. And if we look at age group, we also see that Alaska Natives and American Indians have a tendency to be diagnosed at younger ages. So while about 70% of colorectal cancer is diagnosed in individuals over the age of 65 among whites, that's about 65% of those cases are over age 65 in American Indians and Alaska Natives. So a little bit younger skew. So major points here: colon cancer incidence, mortality in most regions is either increasing or not changing in American Indians and Alaska Natives, while falling in non-Hispanic whites. And American Indians are diagnosed at younger average ages and are more likely to be diagnosed at later stages of disease. So why? Questions are always about why this happens, and I think one of the major reasons is really that screening is underutilized. A lot of the fall in the incidence and mortality among the non-Hispanic white population has been attributed to the efficacy of colonoscopy in taking these polyps out so people don't get cancer, and finding these cancers earlier where they're much easier to treat and survive. There may be other factors. Risk factors may certainly be higher, and that's probably why we see these differences between these regions, with the highest rates being in Alaska and the lowest rates being in the Southwest. But that needs more study. So what are these risk factors? Family history is really probably the most commonly held risk factor for colon cancer. So overall, if one's lifetime risk is 5 to 6%, if you've got a parent or a sibling who had colon cancer, your lifetime risk increases to as much as 18%. And if you have 2 first-degree relatives with colorectal cancer, your lifetime risk can be as high as 24%. That's why it's so important to get those family histories. Obesity is a risk factor for colorectal cancer. We know that we have a weight issue across Indian country. Diet plays a major role. Diets that are high in animal fats and low in fiber and low in fresh fruits and vegetables have been shown to increase one's risk for colorectal cancer. Certainly in the late 60s, malnutrition was a problem on Indian reservations, and that's when the USDA commodity supplement program came in, started bringing in a lot of food to Indian country, and really malnutrition was addressed by these changes. Unfortunately, here we are 50 years later, and we've replaced malnutrition with obesity and diabetes and cancer, these things that can come with this sort of diet. Not a lot of fresh fruits and vegetables over time, a lot of high-fat foods. Risk factors also include diabetes, and I think most are aware that diabetes is at epidemic proportions in our native communities. Daily smoking is also a colorectal cancer risk factor, and it's also a poor prognostic factor for individuals who develop colon cancer, as they have a higher rate of death once they're diagnosed. We also know that physical activity can reduce your risk of developing colon cancer by 40 to 50%. And a lot of the places where Native people live, reservations and things, the built-in environment in those areas make it a little more difficult for people to get regular exercise, rural roads and these sorts of things. And so not a lot of parks, not a lot of, running trails, these sorts of things to help keep people active. But overall, screening is definitely the low-hanging fruit. First, I just want to talk a little bit about the U.S. Preventative Services Task Force Colorectal Cancer Screening Guidelines. These were released back in 2008. And this slide is a little bit complicated and hard to see, but it's really a summary slide. If you look at the top, you'll see that they recommend, obviously, screening individuals between the ages of 50 and 75. Once people hit 76, we're not screening routinely, meaning that if they're up to date, say they had a colonoscopy at 75, they don't have any family history, that probably the benefit of continued screening is not there. However, if you do have adults in this range who have never been screened, and certainly if they have decent health status or are expected to live another 10 years, it'd be a good idea to get them screened. Over 85, the risks of screening usually outweigh the benefit. Not a lot of folks over 85 who are really going to do well with chemotherapy and surgery if we do find cancers. So screening is not recommended. And I think it's really important to point out several things in terms of terminology. Screening means you're looking for polyps or cancer in an individual without any symptoms and who's never had polyps. If patients have had polyps in the past, that's actually, they're in the surveillance population. These guidelines don't apply to people who have had adenomatous polyps. And certainly if they're at high risk for colorectal cancer by way of family history, then those patients, again, are not in a screening population. They're more of a high-risk population. If you look down here, we see the tests that they recommend, either annual screening with high sensitivity fecal occult blood tests, and we're going to come back to that, or doing a sigmoidoscopy, which we'll talk about every 5 years, with high sensitivity fecal occult blood tests every 3 years, or doing a screening colonoscopy every 10 years. And again, this is a screening population. Let's talk a little bit about fecal occult blood tests. This is the Hemoccult. This is a 3-card take-home test. How do you do this test? For those of you who don't know, really you have to do all 3 cards. Each card it has 2 windows. Each card is used to sample 1 stool. So you take a little stick in there, you smear some stool in these windows, you close it, and you send it in. And you need to do 3 of these cards from 3 consecutive bowel movements. Importantly, these go to the lab, they get developed. If they turn blue like this, then they're seeing occult blood. It does not mean the patient has colon cancer. It means there is some occult or microscopic blood in the stool, and that patient needs a colonoscopy. Should never, the reason we do this really ends up with 6 samples. The reason we do multiple samples, and this has to be done every year, is because, cancers and big polyps, they bleed intermittently. And so doing 6 samples, you're really increasing the odds that you'll find that. Again, I talked about the fact, they use the stick, they put the sample of the stool on there from 3 bowel movements. It's important to know with the guaiac-based tests like the Hemoccult, there are a number of things patients need to be aware of. They have to avoid NSAIDs like aspirin, ibuprofen, naproxen, these things for 7 days. Tylenol is okay. We usually don't have patients stop their aspirin if they're just taking an aspirin a day. We also want them to avoid vitamin C and iron supplements, as these can give these can actually interfere with the test. We have patients avoid red meat for 3 days, as well as foods that are high in vitamin C, the citrus fruits and juices. So this is a lot for patients to think about. They have to alter their diet and their medications to get ready for this test. Some helpful hints, patients don't like to handle their stool. The stool shouldn't be allowed to touch the water. Couple ways to do this, you can put like plastic wrap over the toilet and shut the toilet seat. Make sure, obviously, you give yourself a little space for the toilet to go, the stool to go into. If you have an on-off valve right next to the toilet, you can actually just turn the water off to your toilet, flush it, and then there won't be any water in the bowl. Get your sample, turn the water back on, and flush it. In some places, we use the toilet hat. How good is this testing? With guaiac-based testing, we know if you do it every single year, you can reduce the mortality in a population from colon cancer by 33%. So you have to do it every year. If everybody did it every year, you would decrease colorectal cancer deaths by 33%. Unfortunately, if you do it every other year, you lose that benefit. The advantages of these tests, super inexpensive. You can do them at home. Most health systems can afford it, and it does decrease mortality. limitations, again, you've got the food and medication restrictions. People don't like to handle their stool. You got to do it every single year, so you have to have systems in place to make sure that happens. And the sensitivity and specificity for colorectal cancer is a little, you know, it's low, but it does have use, and it is a good test for patients who are really either unwilling or can't afford any other types of testing. There's very little preventative effect from this type of testing. Sometimes a big polyp might bleed, and this might trigger them getting a colonoscopy and getting those polyps out. This is one of the more critical slides. Back in the 80s and 90s, most of the colorectal cancer screening guidelines also accepted doing a guaiac, or looking for occult blood, in specimens obtained from a rectal exam. So the patient's in the clinic, doctor does a rectal exam, wipes a finger on a card, and they guaiac it. This was commonly done in the 80s and 90s. Back in 2005, a group called the VA Cooperative Study, which was a big bunch of researchers from multiple VAs, did a study of over 3,000 patients. All these patients did take-home guaiacs, did the 6-sample take-home test, and also had guaiacing done on rectal exams before having a colonoscopy. This is a busy slide, but I want to say of the 284 patients that actually had advanced neoplasia, meaning they had cancer or a big ugly polyp, the 6-sample take-home test was positive in almost 24%, but the digital rectal exam specimen was positive in only 5%. Only 2 out of 21 patients who actually had colorectal cancer had a positive test when they did this guaiac on a digital rectal exam specimen. So this has really been abandoned by all of the recommending bodies. There's been a lot of work out trying to get everybody to quit doing this. The newer test is the fecal immunochemistry test. It uses a little bit different technology. It actually uses an antibody which is specific to globin, which is a part of the hemoglobin in blood. It's more sensitive for lower GI tract bleeding because globin, as it travels through the GI tract, if you've got some blood coming from the upper GI tract, it's degraded. So, you know, if you bite your lip or have a nosebleed, this test should not be positive, whereas, for instance, the guaiac or the typical guaiac hemocolts can be positive with those. How good are these tests? Again, a little bit complicated slide, but a couple large studies looked at how well FIT performs. They found that these FIT tests were positive in 54 out of 62 invasive cancers, compared to 46 out of 62 with the guaiac-based or hemocolt tests. And if they looked at polyps, people with large advanced polyps, again, the FIT test picked up 35.6% of these versus 18% who were doing the guaiac-based testing. And this just basically says what I said, that the FIT test actually does a little bit better job at finding cancer and polyps. The nice thing about the FIT test, in addition to its performance, is that it's a lot easier for patients to do. There's less stool sampling. There's multiple ways to do these. Some have a little plunger like in the picture up top where you just kind of plunge it in the stool and stick it in a little vial. Others use a little paintbrush where you paint the water next to the stool and put it on a card. But the things that are nice for the patient is that there really are no dietary modifications or medications to avoid. FluFit has been getting a lot of press lately. FluFit is a strategy that has looked at what happens if we give patients FIT tests, or these cards or vials to take home and do a stool test at the time they come in for their annual flu shot. And some very large studies have looked at this with Kaiser Permanente in California and others, and they've shown that they can actually increase screening by 10 to 20%. So 10 to 20% of those patients will actually send it back. Sometimes, though, patients might take that home, and they may not do it, but it also may prompt them to talk to their physician about colorectal cancer screening the next time they see them, saying, you know, I got my flu shot, they gave me this card, I didn't know if I wanted to do that or not, what do you think about colorectal cancer screening? And boom, that might lead them to get screening. So that's one easy strategy to think about when you have your flu shot trial or your flu shot campaign, you might also give them these FIT tests. We'll talk a little bit about endoscopy. There's two types of endoscopy for screening. One's a sigmoidoscopy, where you look at the sigmoid colon, which is basically the first 3 feet of the colon. And then there's the colonoscopy, which requires you to clean out the whole bowel, but in which you look at the entire colon for polyps or cancer. Flex SIGs, again, detect individuals with polyps, so it can be preventable. Notably, if you see a polyp on a flex SIG, the patient isn't prepped, and so you can't use cautery usually, so larger polyps you can't take out. You biopsy them just to make sure they're adenomas. If they have an adenomatous polyp, they actually get sent for a colonoscopy. This method actually detects 70% of patients with advanced polyps and cancer. And the reason is a lot of times with patients who have a cancer on the right side of the colon, where they're not even getting to with the flexible sigmoidoscope, a lot of those patients end up having a polyp within the range of the scope that they can get to. And so they find that polyp, it triggers a colonoscopy, their colon cancer gets found. Limitations, it's not risk-free. Perforation and bleeding risks, as with colonoscopies, are very low. Flex SIGs are really not widely available. Because we don't give IV sedation for them generally, they are more painful than getting sedated for a colonoscopy. The other limitation, of course, is if you have a polyp, you need a full colonoscopy. The one thing I didn't write on here is that the major difference, too, is the prep. Patients for a flex SIG just have to give themselves some enemas. Because they're not getting sedated, they can drive themselves home as well afterwards. Whereas with the colonoscopy, there's a full day of preparation, cleaning out the bowel the day before, and patients have to have a driver because we give them sedation. And again, I just talked a little bit about this. A colonoscopy, of course, has the highest detection rate for colon cancer and polyps. You can take polyps out. It's the most preventative. Complication rates, again, are low but not insignificant. If we take polyps out, there's a 1 in 30 to 1 in 40 chance that site may bleed up to 7 days later. Sometimes we have to go back in and put a clip on it or deal with it. And even with the colonoscopy being the best test, there's still a potential for missed lesions. Studies have shown that we miss as many as 6% of advanced polyps. That's because it's not a straight tube. There's lots of crevices. Preps aren't always that good. You got big folds. Things can hide. Colorectal cancer trends, if we look at the incidence, we looked at mortality already. Again, we see this decreasing incidence or number of new cases predominantly in the white population. The American Indian Alaska Native is kind of the darker gray, kind of bounces around a lot because the numbers are smaller in those samples, and so they're not stable. But that's not a real significant trend in terms of decreasing incidence. This slide just kind of gives you an idea of what we as gastroenterologists recommend based on what we find in people's colons. If you have 1 or 2 adenomas and they're less than a centimeter big, we bring them back in 5 years. If you have 3 or more, we bring you back in 3 years. If you have 1 polyp over a centimeter, we bring you back in 3 years. And if the pathologist tells us that there's villus, it's a villus adenoma, those are higher risk polyps, we bring you back in 3 years. And again, these are patients that are in the surveillance population. These patients are no longer in the average risk screening population. A couple other screening methods out there. CT colonography, I thought maybe 7, 8 years ago that we'd be doing a lot more of this by now, but we're really not. CT performance for polyps over a centimeter, the sensitivity is about 90.9, so they miss about 10% of advanced polyps or cancer. The specificity is about 14%, but what I want to draw your attention to is the positive predictive value, which is about 23%, meaning that persons with a polyp on CT scan have about a 23% chance of actually having a polyp. They see things on the CT scan. It might be a stool ball that fell out of a diverticulum or something else they think's a polyp, and oftentimes those patients don't have polyps. Other issues with CT colonography, was not recommended by the U.S. Preventative Services Task Force, although those recommendations are due for an update. It's not covered by many insurance companies as a primary screening method. Oftentimes they'll pay for it if you have an incomplete colonoscopy or a patient that just can't have a colonoscopy for one reason or another. The CT colonographies are only as good as the experience of the radiologists that are reading them. Probably one of the biggest factors that's limited its use is just the accumulation of radiation. And so when you get a CT scan like this, it's the equivalent of getting between 200 and 250 chest x-rays. So it's a lot of radiation. If you start doing these repetitively to follow or look for polyps, that has been a concern. Cologuard has been in the news a lot lately. This is a newer test. This does both a FIT test and also looks for some DNA in stool samples. And this is actually what the kit, kind of like a cartoon of what the kit looks like. It comes in a box. The sample container and the bracket are used to collect the sample. That bracket sits on the toilet. The sample container, you take the lid off, you put it in there, and you put your stool in there. After you're done, you have to use a little probe to get a sample of the stool and put it in that little tube vial. You also then add that bottle of liquid preservative and mix that up in there, put the lid back on, put it in the box, fill out all the sample labels, and then it has to be FedEx or UPS shipped to the company so that it arrives within 2 days. It's a pretty good test. The data shows that it catches colon cancer and rectal cancer. Its true positive rate is 92%. It seems pretty good for polyps at 69%. But there's also a 13% false positive rate, meaning 13 people out of 100 who do it are going to have a positive result that actually don't have either of those things, and they will get sent for a colonoscopy to prove that they don't have anything. Bigger problems are it's not covered by most insurance yet. And the cost is still $600, and patients may be averse, again, to the stool handling and shipping. Lastly is the dual contrast barium minima. This really isn't used much by anybody for screening anymore. It's really a test that we use if you say we can't get through a sigmoid colon because of the anatomy or something else is going on, or the patient's just too old and sick to even do a bowel prep. We may do a barium minima just to see if they have a lesion in the colon that may be causing some other symptoms like progressive constipation. So, which test is best? The answer is pretty simple. It's the one that actually gets done. So, rather than focusing on what's the best test, we need to focus on the ones that the patients will do, and we need to focus on the ones that the health system can actually afford and the patients have access to. This slide shows colorectal cancer screening rates by age from individuals 51 to 80 by IHS area. And you'll see that we have a pretty big variation in terms of the proportion of the population served by the IHS that gets screened. It's lowest down in the Southwest. Alaska, because of their high rates, have been very proactive with colorectal cancer screening. And literally, if they can do it, anybody can, if you think about their geography and the things they have to do to get people screened. While if you look all the way to the left, you see that the U.S. population, about 65 to 70% of patients are current with colorectal cancer screening. Overall, IHS is 42%. This was in 2011. These rates have actually been improving. And if you look back at when I started in the Northern Plains, we knew that our screening rates were between 16 and 26%. And within 5 years and a lot of work, we've got that as high as 47% in the Bemidji area. So things are changing and things are improving. Why are screening rates low? Well, certainly there are a lot of patient factors, cultural factors, community factors, health literacy factors. We also have a lot of health systems factors that we can improve on. And as everyone knows, there are financial factors that can be barriers. In terms of a strategic plan, we've had a lot of luck with different health systems trying to use navigators. Navigators are individuals that are in the community, often community members. Rosie Morgan is actually she was a breast cancer survivor up at Red Lake in Minnesota, and she developed an interest in colorectal cancer screening, and she bangs on doors, she gets casino cards, she bribes people to get screened, she's a source for people to learn more about screening, and certainly navigators can really help improve your screening rates. Having providers who recommend screening has been shown to be the strongest predictor of screening in multiple studies and in multiple populations. So we have to have doctors who are recommending, you got to get screened. So just take-home points so far. Colorectal cancer is the second leading cause of cancer mortality behind lung cancer. Screening and surveillance can prevent both cancer incidence and mortality. Screening starts at age 50. Unless there's a family history, then we actually start screening lower. And we should not be doing these guaiacs in the office on digital rectal exams. They've got to be the ones that you take home, and you have to do them every year if you're going to use that method. So if you think about colon cancer screening, you have to have several components. You have to have a willing patient, you have to have access to care, and you have to have an enabling health system. And when all those things work together, you get individuals who get screened. Last bit of this talk, I want to talk about the IMPACT study. IMPACT stands for Improving Northern Plains American Indian Colorectal Cancer Screening. And this was a project that was funded through the Indian Health Service. It was actually the first major project of the American Indian Cancer Foundation. It was a 2-year project, and what we did is we aimed to conduct site visits at IHS and tribal health systems. We wanted to look at colorectal cancer screening practices, everything from, do they have patient tracking systems and provider reminders. We wanted to also work with the providers and assess their knowledge and attitudes and beliefs and look at the challenges they had in getting people screened. The framework for the project was this publication, which if you don't know about it, is an excellent resource. This is put out by the American Cancer Society and the National Colorectal Cancer Roundtable, and it's called How to Increase Colorectal Cancer Screening Rates in Practice. And it's available free. It's online. You can download the PDF, and it has a lot of great strategies in it for increasing screening rates. Our scope, again, was the Northern Plains and these states, and we actually approached 54 different sites to participate. First thing we did at these sites was a facility assessment questionnaire. We looked at numerous things, the staff duties on screening. We looked at, do they have an existing screening policy? What kind of methods do they use to identify patients who needed screening? Were there provider reminder systems? What methods were used to counsel patients about the screening options? Did they have a patient navigator available? We also looked at, do they have systems to capture whether patients were actually completing their stool tests and sending them back? Were they tracking results from endoscopy? And did they track those pathology reports and those sorts of things? Secondly, we looked at provider questionnaires and did some focus groups with providers about their beliefs about colorectal cancer screening, when they started patients for screening in terms of their age, what tests they use, perceptions about screening in their communities, and how their clinical systems functioned to promote screening. Again, we approached 54 different sites, and 40 of them actually completed the project. About, I guess, 13, for various reasons, weren't able to actually participate, but we thought that was a pretty good catchment. We actually met with 431 health professionals, including 145 health providers. So let's look at the results. We look at the results in the context of the 4 toolbox essentials from this publication. The first says providers must recommend screening. We know from state surveys that 90% of people who actually get screened tell us that their doctor told them to. Only about 17% of people who said that their doctor has never told them to get screened actually get screened. So again, doctors have to tell their patients to get screened. And we asked these providers about that, and 90% said that they are routinely assessing patients and their colorectal cancer risk factors and their screening history. We asked what age do you initiate screening, and most individuals knew that screening should start somewhere between age 45 and 50. 50 is the actual guideline. And almost all of them knew that if you had one positive fecal occult blood test or FIT test, the patients needed to be sent for a colonoscopy. So it was good. However, we also asked whoever GUIAC digital rectal exams specimens for screening, and 65% of the providers said they did that. And again, we talked a little earlier that this has been a practice that everyone has been trying to really get rid of at the national level because it doesn't work and it gives patients a false sense of security that they were screened. Toolbox essential number 2, we asked you, do you have a colorectal cancer screening policy? Those policies really need to, look at colorectal cancer risk and look at local resources and payer coverage. And there really should be a comprehensive protocol for tracking and results communications. Unfortunately, 90% of the places we went did not have any sort of established screening policy or flow chart of how patients get tracked and lacked a lot of that infrastructure. We asked about reminders, both patient-oriented reminders and provider-oriented reminders for screening. And we found that just about half actually had a system to remind providers when patients were due for screening at the clinic visit. So patients sitting in front of you, is there something there reminding the doctor that they're due for colorectal cancer screening? Only half of clinics. We asked, is there a system that reminds providers when patients are due for screening when they're not in clinic? Do they get a printout every month that says, these are the patients in your panel, and they're overdue for screening? And only 25% of clinics had something like that. We asked, do you use your electronic medical record to track when screening's due? And only 37% of those who have an electronic medical record system actually did. We asked, does your facility give providers feedback on their screening rates? And about half did. We asked, does your clinic send reminders or call patients when you send them home with a stool study and they don't send it back? And only about 1 in 4 of those did. So lots of ways to improve these rates. We asked, how are patients tracked for repeat screening or surveillance? In other words, they're due for it again. And about half of places didn't do any sort of tracking. Then 18% used some sort of paper record, and about a third kept that information in their electronic medical record. How are patients reminded when the subsequent screening or surveillance is due? About a fourth, there is no reminder. You're due for another colonoscopy, but it's up to maybe the doctor sees a chart when you come in and maybe picks up that in his in his visit with you, which may be covering all sorts of different things. Very few were doing any sort of telephone call or mailing. So most of them just kind of relied on that face-to-face visit and that doctor, half the time not having any sort of prompt, figuring out that you're due for screening again. Lastly, the last essential was to have an effective communication system, and this really looks at decision stage-based communication, shared decision-making, and staff involvement in trying to improve colorectal cancer screening. And we asked, do your patients usually just want you to choose a test for them? And interestingly, 82% of the doctors said yes. Lastly, we asked the providers, how much time do you think it really takes to talk adequately about screening? And about half thought it really took less than 5 minutes. There were providers who really felt it took a lot of time to really go through this and explain everything to patients. Overall, 39% of the providers we talked to believe that clinic time demands limit their ability to discuss screening options with their patients. So what are the recommendations based on all this data that I've shown you? I know it's been a lot. Again, all health systems should develop and have a clinic policy. And these policies should be based on national guidelines. And again, this publication is a great tool to help you develop those types of policies. Policies should include how are you going to identify the patients who need to be screened, how are we going to identify what their risk is for colon cancer based on their personal and family history, a method other than just simple clinic catchment for making sure patients are aware that they're due for screening, and how are they going to, how screening needs and risk will be made readily available to providers during their clinical visits and outside that. Other policy, other important things to have in your policies are teaching aids that are available to providers, a method for tracking screening discussions and patient choices, and procedures for tracking ordered tests for completion. Again, provider recommendation is critical. We have to commit to recommending screening to all appropriate patients. Providers need annual training on current screening recommendations. And providers really need to practice helping patients make informed screening decisions so they can do that in an efficient way. So in other words, being able to have a good conversation, but doing it, in 5, 6, 7 minutes so that it doesn't eat up all their clinic time. What does that mean? That means engaging your patients to talk about screening. If there's not enough time to talk about it, to schedule a visit for this purpose, and making sure that we're tracking screening recommendations and